Hello, my name is Dr. Dewan S. Raja. Today I will discuss about systemic lupus erythematosus. The systemic lupus erythematosus or SLE is a chronic autoimmune disease that can affect multiple organs and systems in the body. Its clinical presentation can vary widely among individuals, and the severity of symptom can fluctuate over time. Here is a general overview of the clinical presentation of SLE or systemic lupus erythematosus. This is a fairly common disease with prevalence that may be as high as 1 in 2500 in certain populations. Similar to many autoimmune diseases, SLE predominantly affects women with a frequency of 1 in 700 among women of childbearing age, and female to male ratio is 9:1 in the reproductive age group of 17 to 55 years. By comparison, the female to male ratio is only 2:1 for disease developing during childhood or after 65 years of age. The prevalence of the disease is twofold to threefold higher in blacks and Hispanic than in whites. Although SLE most often presents in the 20s and 30s, it may manifest at any age, even in early childhood. What are the clinical features of SLE? We have many clinical features like skin involvement, butterfly-shaped rash across the cheek and bridge of the nose, malar rash, discoid rash, red scaly patches on the skin that can lead to scarring, photosensitivity, increased sensitivity to sunlight resulting in skin rashes or lesions after sun exposure, joint and muscle symptom, arthritis, inflammation of the joints, leading to pain, stiffness and swelling, often affects the fingers, wrist, knees and ankles. Myalgia, muscle pain and weakness. Systemic symptoms: fatigue, persistent tiredness that is not relieved by rest, fever, low-grade fever are common, especially during disease flares. This happens due to release of some cytokines and other inflammatory substances. Weight loss, unexplained weight loss may occur. Renal involvement, that is the kidney involvement. Lupus nephritis, inflammation of the kidneys, which can lead to proteinuria, protein in the urine, hematuria, blood in the urine, and impaired kidney function. Cardiovascular manifestations, pericarditis, inflammation of the lining around the heart, leading to chest pain, endocarditis, inflammation of the heart valves. We may get deposition, Lipman-Sachs vegetation on the leaflet of mitral valve. Lipman-Sachs endocarditis, non-bacterial verrucous wart-like vegetation on the heart valve, which can predispose to valve dysfunction. So it can involve pericarditis, endocarditis. It may involve pericardium, endocardium and myocardium, all the layers of the heart. Neurological symptom: headache can range from mild to severe. Cognitive dysfunction, memory problem, confusion, difficulty concentrating, seizure, convulsion, and strokes less common but can occur in severe cases. Sometimes there is more tendency for the blood clot to form. That may lead to stroke too. Hematological abnormalities, anemia, low blood cell count leading to fatigue and weakness. The antibody has effect on the stem cells, the bone marrow, that may lead to anemia, leukopenia, lymphopenia, and thrombocytopenia. Pulmonary involvement or lung involvement, pleuritis, inflammation, the lining around the lungs causing chest pain worsened by deep breathing. Pleural effusion, accumulation of fluid in the space between the lung and chest wall. Ophthalmic manifestation, problem in the eyes, dry eyes, conjunctivitis, retinal vasculitis. We can assess it by the ophthalmoscope. Neuropsychiatric symptoms, cognitive dysfunction, impaired in memory, concentration, and other cognitive function. Psychiatric manifestation, depression, anxiety, psychosis, and mood disorders. Seizures, headache, and peripheral neuropathy may also occur. Course and prognosis of systemic lupus erythematosus. It is important to note that all individuals with SLE will experience all these symptoms. It is important to note that not all individuals with SLE will experience all these symptoms, and the severity can vary widely. Additionally, the disease course can be unpredictable, with periods of remission and flares of symptoms. Early diagnosis and management by a rheumatologist are crucial for optimizing outcomes and quality of life for individuals with SLE. Systemic lupus erythematosus is a complex autoimmune disease characterized by dysregulation of the immune system, resulting in inflammation and damage to various organs and tissues in the body. While the exact cause of SLE is not fully understood, it is believed to involve combination of genetic, environmental, and hormonal factors. Genetic factor, this is evidence to suggest a genetic predisposition of SLE. Certain genes associated with immune system, such as those involved in clearance of apoptotic cells that have been undergone programmed cell death, and genes involved in immune regulation have been implicated in the development of SLE. However, no single gene has been identified as the sole cause of the disease. Instead, it is believed that multiple genetic variation along with environmental triggers contribute to the development of SLE. Immune dysregulation. In SLE, there is dysregulation of both the innate and adaptive immune system. This dysregulation leads to the production of autoantibodies, which are antibodies that target the body's own tissues and cells. These autoantibodies form immune complexes with self-antigens such as nuclear antigen, that is DNA, histones, ribonucleoproteins, and deposits in various tissues, triggering inflammation and tissue damage. Additionally, abnormalities in the function of various immune cells such as B cell, T cell, dendritic cell, and macrophages contributed to the pathogenesis of SLE. Abnormal apoptosis and clearance of apoptic cells. Apoptosis or programmed cell death is a normal process in which old and damaged cells are eliminated from the body. In SLE, there is impaired clearance of apoptotic cells, leading to the accumulation of apoptotic debris. This can trigger an immune response and the production of autoantibodies against self-antigens exposed during apoptosis. Okay, so susceptibility genes here, B and T lymphocytes specific for self-nuclear antigen, interact with the with the increased burden of nuclear antigens, defective clearance of apoptic bodies, so there will be increased burden, and external trigger, that is ultraviolet radiation, may stimulate apoptosis abnormally. There will be defective clearance of apoptotic bodies, antinuclear antibody, antigen-antibody complexes will develop, endocytosis of antigen-antibody complex, and toll-like receptor engagement by the nuclear antigens. TLR, or toll-like receptor stimulation of B cells, and DCs, that is the dendritic cell or antigen presenting cell, stimulation of B cell and T cell by interferon. Okay, what happened? Persistent high level antinuclear IgG antibody production. If you go to the histopathology, there will be degeneration of the basal layer of the stratified squamous epithelium. There is edema at the dermoepidermal junction. Okay, and here in immunofluorescence study, we'll get the deposition of IgG. Here is the deposition, Liebman sac vegetation on the mitral valve here. And these images have been taken from Robinson Cotton Pathologic Basis of Disease, 10th edition, Kumar, Abbas, Nestor, Elsevier. Okay, let us continue on pathogenesis. Cytokine dysregulation. Cytokines are signaling molecules produced by immune cells that regulate immune response. In SLE, there is dysregulation of cytokine production, leading to the production of pro-inflammatory cytokines such as interleukin-6, tumor necrotic factor alpha, TNF-alpha, interferon-alpha, which contribute to inflammation and tissue damage. Overall, the pathogenesis of SLE is multifactorial and involves a complex interplay between the genetic predisposition, environmental triggers, and dysregulation of immune system. Understanding this mechanism is crucial for the development of targeted therapies for the treatment of SLE. What are the triggers for SLE? Environmental trigger such as exposure to ultraviolet light, certain medication like hydralazine, procainamide, is antiarrhythmic drug, antihypertensive drug, and some anti-seizure medication, infections such as Epstein-Barr virus infection, hormonal factors such as estrogen, specifically during pregnancy and during the stress period of menstrual cycle, have been implicated as triggers for the development of SLE. These triggers can activate the immune system and contribute to the production of autoantibodies and inflammatory response seen in SLE. Differential diagnosis. Rheumatoid arthritis, family history, and joint involvement may overlap with SLE. Dermatomyositis, rash and muscle weakness can mimic SLE manifestation. Sjogren's syndrome, Zika symptom, exocrine gland will not produce the secretion, and positive antinuclear antibody may be present in both conditions. Fibromyalgia, there will be fatigue and muscle pain. Diagnostic investigations. Complete blood count may be normal initially but may have anemia, maybe hemolytic anemia, lymphopenia, and thrombocytopenia because the antibody act on the bone marrow stem cell and suppress the blood cell formation. ESR, erythrocyte sedimentation rate, is elevated, C-reactive protein elevated, antinuclear antibody positive, antiphospholipid antibody positive, anti-double-stranded DNA antibodies positive, so this is very important. Urinalysis, proteinuria and hematuria, that is passage of blood through the urine, passage of protein through the urine, direct Coombs test, again to confirm the hemolytic anemia. Treatment of systemic lupus erythematosus. Non-steroidal anti-inflammatory drug for symptomatic relief of joint pain. Hydroxychloroquine for skin and joint symptom to reduce disease flares. Corticosteroid for severe manifestation or flares. Immunofluorescence, immunosuppressive agent, that is methotrexate, mycophenolate, mofetil for refractory cases of lupus erythematosus. Okay, and that's all about the systemic lupus erythematosus. If you have any question, please feel free to ask me. Please share the information with your friends. Please support my channel. Please subscribe me. Have a nice, wonderful and blessed day. Bye now.